Once I am done, and I'll tell you when I'm done telling you about myself, the timer, we'll set a timer for 5 minutes. You, as the physicians, get to ask me questions. All of you do. And then you'll have 2 minutes to work together to decide what tests you want to run. The accountant keeps track of how much all that costs. And the attending will tell me what test you're going to run, what you're testing for, and I'll tell you if your results were good or bad. Okay? So here are the options. I always come for 2 visits. So you always have to pay for 2 visits. But if you successfully diagnose me, you get $1,200. But I paid for 2 visits, so you lose $200. If I die, if I have a fatal condition, I sue you for malpractice and you go bankrupt. If I recover but you didn't treat me appropriately and I either had to go somewhere else or I finally cleared the infection on my own, I still am going to sue you, but it's only $500. But of course, you actually don't really get to go into debt. We restart with 0. And that's how much everything costs. Right? You can't go into the negative in terms of you can't do $3,000 worth of tests because I'm only going to pay you, right? You're only going to get paid $1,200 minus the $200 for my visits. So you can really only do $1,000 worth of tests. Otherwise, you go bankrupt at the hospital. Okay, so these are the things that you can decide to do. But note, if you are like, oh, we want to do an ELISA, for what? You have to have an idea of what's wrong with me. Or a PCR, for what? Right? Nucleic acid testing or sequence, for what? You have to know. Okay? So you either treat me, I go somewhere else, or I die. And two of those things I will sue you for, or my family will. Okay? I don't want to sue you. All right. Are you ready? I'm a 20-year-old female. I have come to the clinic because within the past 4 or 5 days, I haven't been feeling well. I feel tired and achy, and my throat hurts, and I've developed a cough, and I'm not functioning like I should be. So I need some help. So you now have 5 minutes to ask me questions and figure out what's wrong with me. And you can all move together and everybody can ask a question. You can just shout out questions if you have them. So you have 5 minutes, timer. Yes.
Do you smoke?
I do not. Yes.
Have you gone through any other treatments or procedures recently?
I have not. No.
Any fever?
Yes. Ask me. You can ask me. Anybody can ask me something. I heard you ask, did I vomit? No, I haven't been vomiting. No vomiting, no diarrhea.
Oh.
Have you traveled anywhere?
I have not traveled, no. There's nothing wrong with me. There's something wrong with me. I'm gonna sue you. I'm like, all right, let's see here. This,
Would it be a good idea to ask about vaccinations?
Yeah, vaccinations.
What about vaccinations?
Are you up to date on all your vaccinations?
Yeah, I just got my flu shot and my COVID booster 3 weeks ago. They were free at CVS.
Do you feel like your lymph nodes in this area are different? Like,
Well, you're the doctor, but you can't touch me, like in real life. But if you were examining me, yeah, I have some swollen lymph nodes.
okay.
Yeah.
Wait a second.
Do you have any abdominal pain?
Like if you press like hard on my abdomen, it hurts, but I don't have like cramping or any of that kind of like pain. But if you press on my abdomen, it does hurt. Yeah.
And do you have a problem with breathing?
I mean, I'm congested, but it's not like I have trouble catching my breath. I'm just like I am congested though.
To do what?
Ask
Like
questions.
any only questions?
Yeah.
Okay.
It's been 3 minutes already?
Yeah.
Yeah. I'm sitting here suffering. I'm suffering. I'm sick. What else do you want to ask me?
You're age, right?
No, I'm 20.
20.
I wish, man. I wish I was 20. No, in the scenario, I'm 20. Yeah. I'm a 20-year-old female.
What's your living situation?
What's my...
Yeah, living situation. Do you live alone? Do you?
Oh, I live in an apartment with some roommates. Yeah, we're kind of broke, so there's like 6 of us living in a 3-bedroom apartment. Yeah.
Any more questions? Anyone?
30 seconds.
No more questions?
Anybody have any other questions? I heard like you have 30 seconds left, so any other questions?
Like sneezing or running nose?
Just kind of like standard congestion, just not feeling well.
10 seconds. Last question.
Okay. So now you'll take 2 minutes to decide which test you want to do. So if you have thought of what disease you think I might have, pick which test or tests would be most confirmatory so that you can get a positive result. So you can take 2 minutes to discuss among yourselves, but the attending physician is the one who gets to make the final decision. So remember, because the attending is always the boss at a teaching hospital. So the attending is kind of the one who really signs off on it. The senior resident makes sure that everybody gets a chance to give their opinion. But of course, you can't listen to everybody's opinion because you can't run every test. So if you're, as the attending physician, you probably want to choose the 1 or 2 tests you think will be most confirmatory. If you can do it in 1, great, you make more money for the hospital. If you need 2, or you think you need 2, that's okay too. So take 2 minutes starting now to talk about what test you want to do.
So you're doing it for FCR?
You have to pick the infection. Yeah.
You guys want to test for FCR?
And you have to pick the right test for the infection. You don't have to do two. You can only do one if you think one will give you the answer. Make sure everybody's well, at least make sure the majority of the group is happy. And then the attending will order the tests. So if you're ready before the time is up, you can order the test before the time is up, or you can talk about it until the time is up. Yeah, you have 2 minutes. Yeah. It's like Doctor on Demand. You only get like 15 minutes, like total. I love Doctor on Demand. That's so great. It's the best. Then I don't have to go to Turlock General. Okay, what tests are you going to order for me?
We are trying to order you the lyse nucleic acid, one from the lymph node and one for the back of the throat.
For what? You're doing an ELISA and a nucleic acid test
Yes.
from 2 different locations? So you're doing 4 tests total?
No, we're doing 2 tests.
1 ELISA and 1 PCR?
No, we're doing 1 test. So 1, 2, and also 2 from the lymph nodes and 1 from the back of the throat.
For what test? ELISA?
Yeah, ELISA, and that's for the
Epstein-Barr?
Yeah, you can get
You want to do an ELISA for Epstein-Barr using a sample from the lymph nodes. You're going to do a biopsy of my lymph nodes?
No, sorry, the back of the throat. I want this bit.
Okay, I'm going to help you out with this one. If you're going to do an ELISA, you probably want my blood. That's where my antibodies are going to be. So you want my blood. That's fine. You want to do an ELISA testing, and you wanted to do a nucleic acid test as well? That's fine. And you want to do both of those for Epstein-Barr.
Yes.
Okay. Okay, so I left the clinic because you took my samples, you're gonna do my test. I'm back for my second appointment. You did an ELISA and a PCR for Epstein-Barr. Those were both positive. I do have mono. So I'm not gonna sue you. Okay, but I still don't feel good. So what are you gonna do for me? What kind of treatment can you give me? You have 1 minute to give me a treatment. Your second visit is short because, you already figured out what's wrong with me. Are you gonna give me a treatment? And if so, what are you going to give me? Is there anything you can give me? I'm the patient. What do I know? I just want to feel better. I feel bad.
Can we give two?
You can give whatever you want as long as you don't go over $1,200.
So we
How much are opioids?
How much are opioids are not on the list? Well,
I know.
I mean, I guess let's say you want to give me a pain reliever. It could be it could be an opiate. It could be like extra strength ibuprofen. $100 to give me a pain reliever.
Okay. So would antiviral, anti-inflammatory to bring down her inflammation?
So that's what you want to give me, an antiviral and an anti-inflammatory?
Is there anything else?
I like that. Was that $500 total?
That makes me happy. I'm happy to have an anti-inflammatory.
How long should we? Does the month?
2 and 2, 4 and 4 was already deducted, so total of 600.
Yeah, because I have to come twice, so 2 visits.
Oh, right.
So you diagnosed me. You gave me treatments that made me happy. You could have also told me, like, go take a nap. You can prescribe, like, you should rest. Here's a note so you don't have to go to work or school. So you can do those kinds of things. You could tell me to go get some, cough drops because my throat hurts. But yes, you can also prescribe the anti-inflammatory. I'm happy with that. And I'm happy with an antiviral. That's good too. So yeah, good job. And you ended up making about $600 or so? Cool. I didn't die. Yay. Okay. So again, these are situations where, if you had asked me, have you been to parties recently? I might say, oh yeah, my friends are in the sorority, so we always go to these frat parties. Everybody's, partying and drinking. Like maybe I would have told you that kind of thing, but I'm not gonna up front be like, oh, so I go out with my friends all the time. What are you gonna tell your doctor? When they ask you, you might be like, oh yeah, I party a little bit, or, I go to college, I live in the dorms. So that kind of stuff is good to think about what you're gonna ask to really get at what is wrong with your patient. Okay, cool. So then let's move on. Wait, let's see who's here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Perfect. I know who's not here. Okay, good. So you get credit for the in-class activity today. Blah, blah, blah. All right. So, like I said, we'll skip parvoviruses because...
Are we gonna get questions like this in the exam?
No, probably not. I mean, well, sort of, yeah, you get the case studies. So we'll do case studies on the exam for sure. And then we'll have more questions like this, as we go through the semester. So sometimes we'll do the regular case study. Sometimes we'll play this game. It just depends on what we've got. So we're going to skip parvoviruses. They're not terribly common. But of course, my brother always managed to bring something weird home. So, we got that once too. And we'll jump into the Picoronaviruses. So Picoronaviruses are a little bit more common. And now we have left the DNA-based viruses and moved into the RNA-based viruses. So one of the things to think about, if we play this game again, or as you're thinking about how would you diagnose these types of viral infections, is that when you want to do nucleic acid testing for an RNA virus, you have to do a modification of PCR. Their genome is not DNA-based. Classic PCR amplifies DNA. So what you have to do first is do, it's called a reverse transcription PCR, or RT-PCR. You have to use reverse transcriptase to convert RNA to DNA so you can do the PCR. So it's a modification of PCR. So if we were playing this game and it's an RNA-based virus and you say you're going to do PCR, it's not going to work. Okay? So you have to think about the genome, and how that would affect how you might do your test. So Picoronaviruses are small, naked, single-stranded RNA viruses, and you'll see there's a plus there. That means the RNA genome looks just like an mRNA. It's directly ready to be translated into proteins. In fact, experimentally, if you take the genome of a Picoronavirus, just the genome, and inject it into host cells, those host cells will be infected and they will begin making viral proteins. So it can immediately be translated into proteins. Because they are naked, they are extremely resistant to adverse environmental conditions. We'll talk about, there's a whole group of them called Enteroviruses that are transmitted through the GI tract. So, they're resistant to the stomach acid and things like that. As with the majority of RNA viruses, they replicate completely in the cytoplasm. They do not go into the nucleus. They have no need to. Right? So they can have their genome immediately be translated. They can encode those polymerases to make their RNA-based genome. They don't need that host transcription and replication machinery that's in the nucleus, so they can stay in the cytoplasm. Usually an infection with a Picoronavirus is going to be a lytic infection of the cells. So again, the genome resembles mRNA. It actually has a 5' cap and a poly A tail. And like I said, if you inject the RNA directly into the host cell, it will cause infection. The majority of them lyse host cells. They lead to host cell death. They inhibit synthesis of host cell proteins, so they outcompete for protein synthesis because they're using the host cell ribosomes to make their own proteins. These are generally very rapid progressing infections. Within 3 to 4 hours, the burst size is about 100,000 viral particles. So pretty quick, and a lot of virions. Okay. So the first group of Picoronaviruses we'll talk about are the Enteroviruses. So they have the name Enterovirus, just like when we talked about Enterobacteriaceae. They're called Enteroviruses because they transit through the GI tract. They are transmitted through the fecal-oral route. The trick here is that they actually don't cause GI infection. So these are not viruses that typically cause things like diarrhea or vomiting. So they go through the GI tract, but their target tissue is somewhere else. And so some of the viruses are listed here. There is just a group called Enterovirus. Hepatitis A belongs to this family. Polio belongs to this family. If you have kids, you probably know about hand, foot, and mouth disease. That belongs to this family. But again, skin, muscle, brain, meninges, liver, none of them are GI tract. So they transit through the GI tract. Once they get into the GI tract, they leave, go into they can go into the bloodstream to get to their target tissue. They'll go back into the GI tract to be shed in the feces. Okay, so they are transmitted through the fecal-oral route, but they cause symptoms in other parts of the body. In the Enteroviruses, in the group Enteroviruses, the most infamous, I guess, I don't know if you want to call a virus famous, infamous Enterovirus is polio. So polio, again, is transmitted through the fecal-oral route. What the virus does when it gets into the new host is it travels up the nerves, and it can go to the brain, and it causes paralysis as it's destroying the nerves as it's moving up. So it travels from the gut nerves to the brain. What is really important in terms of looking for things like polio is actually wastewater surveillance. So patients can be shedding active poliovirus in their feces before the development of symptoms. And so in a lot of places where they still have cases of polio, one of the things that they do is monitor the wastewater, because you can see before there's a spike in polio cases that there's a spike in polio in the wastewater, so they know it's coming. And so then you can also help ensure that more people don't get infected, because you know it's coming. So you can tell them, hey, it's coming, let's do massive vaccinations. In the case of enteroviruses, antibody is the best defense, right? You have your secretory IgA, and then you have the antibody that circulates through your bloodstream to hopefully bind the viral particles that get released from infected cells. So even though polio is kind of the most famous of the enteroviruses, the first one we'll talk about is hand, foot, and mouth disease. So hand, foot, and mouth disease is a broad term that describes more the symptoms, not necessarily like there's one virus that causes the disease. We see a similar thing with hepatitis. So hepatitis is just a liver infection. There are lots of different viruses that can cause hepatitis. So hand, foot, and mouth disease, there are multiple viruses that can cause hand, foot, and mouth disease. They're all Picoronaviruses. The majority of them are Enteroviruses, but there's another group of viruses that can cause them as well. These are common. This is a common disease of childhood. It goes around daycare centers a lot. And again, with the enteroviruses, and Coxsackie is a type of enterovirus too, but it's in a different, I don't know, the terminology sucks here. I'm sorry. It does. There's like a broad family of enteroviruses and then like subgroups. So Coxsackie is a subgroup of the broad enterovirus, but enterovirus is also a subgroup of that. So they're all transmitted through the GI pathway, so fecal oral. So you see a lot of fecal oral infections go around in daycare settings because kids don't have the best hygiene, right? They use the restroom, maybe they don't wash their hands, they touch everything. These are very environmentally stable because they're non-enveloped, right? They're naked. And then other kids touch things and put them in their mouth, and then you're the poor daycare worker like trying to clean up everything, and then you probably get it too because you put your hands in your mouth. You don't think about it, but everything's covered in kid poop. So that's how these things spread.
Question. As you said, the main targeted area is it the blood or is it the cell for the coronavirus? So does it affect the blood more or does it affect the cells?
It depends on the virus. So the Picoronaviruses, like this group is transmitted through the GI tract, but then they go to different target tissues to actually cause symptoms. So they leave the GI tract, or so you ingest it, right? It's fecal oral. So you get it in your mouth. From there, they can get into the bloodstream, go to whatever tissue where they're going to cause symptoms. Then they go back to the GI tract and get shed in the feces. So they transit through the body a lot. So what hand, foot, and mouth, the target tissues are the hands, the feet, the mouth, like the epithelial cells, basically. And you get these rashes. Apparently it's a common disease of childhood. This is one that I actually managed to not get as a kid, and I don't really know anybody that had it. But it, in some cases, can cause meningitis or encephalitis. So especially with your pediatric patients, meningitis and encephalitis are really dangerous, right? Kids are generally more sensitive to these types of things than adults are. Viral meningitis is tricky to diagnose. You can tell, I think it's viral meningitis, but which virus is causing it can be really challenging to determine. And if they have viral meningitis, it can be very difficult to treat because we don't have a ton of antiviral therapies. So that these types of things, when they do cause meningitis or encephalitis in our pediatric patients, can be really dangerous. And so then this is a headline from a few years ago of 2 dozen cases of hand, foot, and mouth disease. Mostly circulating through daycare settings. But again, the more infamous, famous enterovirus, which is a Picoronavirus, is polio. So I have here polio eliminated from the Western Hemisphere, still found in the Middle East and parts of Africa. And I really, I need to clarify that, I think. So there are two, and the question at the bottom kind of alludes to what I'm getting at here. There are 2 types of polio. There's polio that we call wild polio that can circulate through a population. The other type is called vaccine-derived polio. They are different in terms of the vaccine-derived polio is usually a lot less severe, but genetically, you can tell the difference if you do the reverse transcription PCR and sequencing. You can tell the difference. And what we see now, or what we've at least seen through this year, there are only 3 countries in the world that have had cases of wild polio. Combined, there have been 13 people in the world who have gotten a case of wild polio. 1 in Mozambique, which is weird. I think it's probably a travel associated, but I didn't dig that deep into it. The other 12 were in the region that we know is still got a few cases of polio, and that's Afghanistan and Pakistan. So really, wild cases of polio for the past decade or so have been in Afghanistan and Pakistan. And there aren't that many, like 12, not a lot. Okay. Vaccine-derived cases we still do see in Pakistan and Afghanistan, other parts of the Middle East, and also in parts of Africa. And these are as a result of patients who have been given a live attenuated vaccine. So there are 2 forms of the vaccine. One is an injected polio vaccine, IPV. It is a killed virus, like an inactivated virus. And remember, things don't come back to life. So even though we don't consider viruses living, if a virus is inactivated, it's not a zombie. It doesn't come back to life. The other polio vaccine is the oral polio vaccine. The oral polio vaccine is the one that is the live attenuated. So what that means is that the virus is still capable of replicating. So in theory, it should be a weakened form of the virus that is capable of replicating, but should not cause disease, and definitely should not cause disease with symptoms to be recognized as, hey, I think I have polio. But what we sometimes see with the oral polio vaccine is that it can revert back to a more virulent form. So we see patients who have vaccine-derived polio. And the thing is, because this is a fecal-oral fecal-oral virus, let's say I was vaccinated with the oral vaccine, and for whatever reason, in me, it reverted to a more virulent form. So I'm experiencing symptoms of polio. Remember, this virus is shed in the feces. So I would be shedding active virus. It's vaccine-derived, but it still is active. So that means anybody, like let's say we live in an area without the best water treatment. It is possible then that I could spread polio in my local area. And that's what we tend to see in the other parts of the world that still have polio. A patient will have a case that develops that the vaccine strain has reverted to be more virulent, and then that strain can kind of circulate through the population a little bit. It's not even in the thousands how many times this happens, maybe a couple hundred per year. And then that might maybe that piques your brain a little bit. Well, in the US, we use the inactivated polio vaccine. So why do we not use the inactivated polio vaccine in other parts of the world? Why are we using this oral polio vaccine if it reverts back to being virulent? And the problem, or the reason that we do that, is in the US, polio is eliminated. There is no polio in the US. We don't get polio. We haven't gotten polio for decades. So we can use a vaccine that maybe doesn't provide the most robust immune response. Inactivated vaccines don't give you the best immune response. The live attenuated oral vaccine hits the target tissue because you're going to get the virus from something contaminated with feces that you ingested. So the oral vaccine is delivered the way you would get the virus. It is living, right, as a virus, as much as a virus lives. So you get the immune response in the right place, and it's more robust. So that's the risk that we're running when we vaccinate people using the oral vaccine. It gives a much better immune response. It has done very well at keeping wild polio from really taking over and reducing the number of cases every single year. But we run the risk of the vaccine-derived polio in patients. And really recently, within the past month or two, somebody came back from travel somewhere that had been vaccinated with the vaccine strain, and they were shedding polio in New York. Like the wastewater treatment was identifying vaccine-derived polio in the wastewater in New York. So that's the risk, but that's why we do it. So, those are the pros and cons that you have to think about. An inactivated vaccine where the disease is normally eradicated is great. We don't have polio in the US and we haven't for decades. So it's fine. But in parts of the world where they still have polio, they need the best immune response possible, and so that's why they still do the oral vaccine. So there are 3 types of polio. The most dangerous type of polio is type 1. So like, if we were talking about bacteria, we would talk about bacterial strains, right? Type 1 causes paralytic polio, the most severe form. Types 2 and 3 of the virus cause a less severe form. Those tend to be the 2 strains that we use in the vaccine. And those are the ones that sometimes can revert back to being virulent. So it's not usually the most dangerous paralytic form that we're using in the vaccines. So with polio, the majority of the outcomes, most patients are actually going to be asymptomatic, 90% or so. 5% of patients might experience a mild illness or a minor illness. 1 to 2% may experience aseptic meningitis. So aseptic meningitis means it's not meningitis caused by bacteria, right? Aseptic, there are no bacteria. And they also may have back pain and muscle spasms. And then a very low percent will develop paralytic polio. And so if you've ever heard of like an iron lung, people with paralytic polio, sometimes like their diaphragm just doesn't work. So they have to have a machine that helps them, it provides the right pressure to help them breathe. And the iron lung is one of those things that people used. Okay, so paralytic poliomyelitis, like that most severe form of polio, is a flaccid paralysis, meaning you can't control your muscles, but it is not paralysis with sensory loss. So when we think about paralysis, we often think, well, you can't move your muscles, but you also don't feel anything, right? That's like on TV, oh no, I can't feel my legs, right? That's not how this works. You can't move them, but you can still feel them. I think that would probably be worse. I'd rather just not feel them if I couldn't move them. It can involve only a few muscle groups, or it could be much more severe and systemic. Sometimes people recover, maybe 6 months to 2 years, right? The nervous system takes a long time to recover. Neurons take a long time. Some patients experience what they call bulbar poliomyelitis. Basically, the virus has targeted the nerves that feed things like the pharynx, the vocal cords, and control your respiration. As you might imagine, if you cannot control your respiration, you have a very good chance of dying. And then post-polio syndrome would be like the development of polio symptoms years after the infection. And anywhere from 20 to 80% of people who had polio may develop post-polio syndrome. When you're trying to diagnose polio meningitis, the central nervous, the cerebrospinal fluid, right? The cerebrospinal fluid, you would do a spinal tap. That's what you do for most meningitis. Is going to mostly be clear. You're not going to see like the cloudiness that you might see with bacterial meningitis. You're not going to see invasion of immune cells, and you're not going to see really adjusted levels of sugars. The virus is just in there, right? And again, what they're trying to show you here is the antibody response that you get from the inactivated or the live vaccine. They both give you decent, like serum IgG, which is fine if if you're got the virus circulating in your bloodstream. But if you do the live, you get nasal IgA, so you get secretory IgA, you get serum IgA, you get duodenal IgA, so you get the antibody more in the places where you might be exposed to the virus. It can be isolated from the pharynx or the feces, and you can grow it in monkey tissue culture. You're going to, if you're going to try to diagnose it, look for viral RNA or specific antibodies. And again, there are the 2 polio vaccines available. This is the compare and contrast of the polio vaccines, which we kind of already talked about. And then this is the most recent polio numbers. Well, not the most recent, but I think there's August numbers now, but this is from March. So wild type poliovirus number 2 was eradicated in 1999. Type 3 was eradicated in 2020. Type 1 has been diagnosed in 3 countries, I already told you, Pakistan and Afghanistan, and then Mozambique. And then here was polio detected in New York wastewater. So he was tested positive in 2022, but the virus had circulated widely in multiple counties. So, okay, we'll pick up on Monday with rhinoviruses, everybody's favorite, the cold.